Tēnā koutou, ko Justin O'Sullivan toku ingoa, ko te manataki putahi ki Liggins o Waipapatū Matarau. So I'm Justin O'Sullivan and I'm the director of the Liggins Institute, and it's my distinct pleasure to welcome you all here tonight to a lecture which is very aptly entitled Miracle Medicine, How Antenatal Steroids Revolutionised Neonatal Care. But just before we get into that, there's a few things I have to say first. So it's a bit like on a plane. If the lights go off and there's sirens here and here, at the back, please walk, don't run, meet out the front in the quad should that occur. Bathrooms are outside by the main entrance as well. And if I can ask you, and if you haven't done it already, please turn off your cell phones because it's always embarrassing when my phone rings. So I've done it already. So stories are something that are really important to us. They enable us to connect with one another, to relate our shared and individual past, to investigate our possible futures. As social beings, this is the essence and the very core of who and what we are. As scientists, narratives are critical to what we do, how we explain what we've seen, and how we understand the world around us. For myself and those people that work with me, we make narratives that explain how a gene might link to a disease or a particular trait that people have. For others, the stories are real, and are shared experiences with the people who are actually a part of the studies that they undertake. Tonight, we're really privileged to be here to share a particularly powerful story that really does reflect true insights and ambition. I wrote my speech today. The stories we will discuss tonight, scientific and personal, have emerged from what is one of the most impactful interventions to have ever come out of New Zealand. Mont Liggins and Ross Howie demonstrated that antenatal corticosteroids administered to pregnant women threatening to deliver prematurely can actually cross the placenta and induce a wave of cellular differentiation that results in a reduction in respiratory complications and saves the lives of premature babies. In fact, it's been argued that this discovery represents the greatest collaboration between an obstetrician and a paediatrician in medical history. So this is a story of science, but it's also a story of people. And tonight, we're actually really privileged to have with us here as guests in the front rows some of the people and the original participants from Mont's trial, with their families and their friends here as well. So we invited these individuals to share some of their stories with us. We thought that they might like to do it themselves, but what they did is they offered me to do it for them. So it's my privilege now to discuss number 8. So not The Wire, but Penny Babbage. And Penny's here with her mum, and I met them and talked to them just before. So this is Penny's story and her mum's story as well. So Penny's story, her parents were in the process of grieving for their previous son and daughter. And they were in the complex joy, apparently, of having adopted an older brother in about 1969, when she became pregnant again. Penny's birth in 1970 was 9 weeks early and was filled with some great dread by her parents and her grandparents. I guess also with sort of joy as well. But one of the first comments her mum heard from a family member apparently was, "Well, at least she isn't blue." And that's a picture of Pam and Penny there. Sorry, Pam, I should have said your name before. So arriving at 2 pounds in weight, her journey of care started at National Women's Hospital and with Sir Mont Liggins. So Penny and Pam had the pleasure of meeting Mont Liggins multiple times, visiting the neonatal ward as a child, as an adult, with her own children here at the Liggins Institute. Mont actually confirmed that she was number 8, and apparently that's what he used to call her. Yeah, it's, from people that know Mont, I think they don't find that unexpected. But she does remember some follow-up visits by the National Women's Team in the late 1970s when they travelled to the primary school and did testing, how fast she could jump, bend, how good her coordination was, and the nurses' caps were always really white and starched. I think there's just a couple of things that have changed since then. So this has been a lifelong relationship of acknowledging the timing of the study, the impact of the discovery on creating that family unit, and the monitoring of the research, which has really helped to develop a 50-year history of data supporting the amazing discovery. And the trial was by a small New Zealand medical team here in 1969, and it's had worldwide impact on premature baby survival rates. And so they say congratulations to all who have continued with researching and developing this treatment further, and they continue to be very proud to have been part of this journey with us. And I think that's something that's important, not just for them, but also for people like me. So in my job, I get the privilege not only of talking and introducing Penny, but also one of the most eminent scientists in the country. So it's my pleasure to introduce distinguished Professor Jane. Later. Distinguished Professor Dame Jane Harding. So Jane is a neonatologist based here at the Liggins Institute, and she's the president of the Royal Society at Te Aparangi. Her research concerns growth before and after birth, blood glucose regulation in the newborn, and the long-term consequences of treatments that are given around the time of birth. Amongst her many awards are the Howard Williams Medal, the Royal Australasian College of Physicians gave her that one, the 2019 Woman of Influence Supreme Award, the Rutherford Medal from the Royal Society of New Zealand, that was before she became president, and the Prime Minister's Science Prize. So Jane is a phenomenal mentor, personal inspiration to me and to all of the Liggins. And so with that, I'd like to introduce Jane, who will take you through the talk this morning. Thank you.
Thanks, Justin, and it's just wonderful to see you all here tonight. Thank you for coming. It's my pleasure to just open the session with a little bit of background about how it all started and how I ended up in the middle of it entirely by accident. There'll be 3 subsequent speakers. Each of them will introduce themselves, so I'm not going to waste time doing that now. But I would like to just start with how I see the story looking back. And it starts back in the 1960s, at the time we've been talking about. This is the survival rate for small babies. And the first few numbers are in the 1960s. The yellow bars are the babies weighing 1,000 to 1,500 grams, so 2 to 3 pounds, roughly. And the black bars are the babies weighing less than 1,000 grams, less than a kilo. And I think you can see that back in the 60s, survival rates were not good, which is undoubtedly why the story we've just heard is about the extreme anxiety that accompanied a baby who was going to be born 9 weeks early. Because the outlook was not good. Why? Because a large number of babies died from respiratory distress syndrome. And this is a little baby with respiratory distress syndrome. You can see their lungs are really stiff, and its little chest is being sucked into its backbone because the lungs are so stiff as it tries to take a breath. We know now, but didn't know at the time, that that's because a substance called surfactant, which helps keep your lungs open and expanded, is not produced until late in pregnancy. So preterm babies didn't have enough of this stuff, and they got terrible lung disease, and they died of it. So in the 1960s, National Women's Hospital opened. Here it is, the opening session down the bottom there. This is what a delivery room would look like in the 1960s, but different from today. Respiratory distress caused death. And Mary Ellen Avery was just working out the role as surfactant in this nasty disease. There was at the time only one paediatrician in Auckland who could manage a ventilator, which was fairly primitive, and when he went on leave, babies died. And obstetrics gave the wooden spoon for evidence-based medicine. It was considered there was so little evidence to base treatment in obstetrics and newborn care at that time. But there was hope. This is the 1960s, National Women's Hospital. Liggins and Howie were working at National Women's Hospital doing research. They were keeping the sheep they were working on in Cornwall Park next door. And in a series of very elegant experiments, they were focused on what causes preterm birth. And they showed very neatly in sheep that it was a rise in steroids in the fetus that started the process of labour. And they showed in sheep that if you stopped that rise, labour didn't happen. And if you stimulated that rise early by giving steroids, then preterm birth happened. But the remarkable thing was not that research. It was the fact that Mont, working in an old bike shed in the back of Beyond, observed that a lamb who had been born early, who'd been born early because they'd received steroids, was breathing. And he said it had no right to be. In other words, all these lambs died of lung disease. What was going on? Well, Mont reasoned in, I think, a remarkable insight that it was the steroids that had accelerated the maturation of the lungs and let this lamb breathe. And if it worked in lambs, it ought to work in people. Backtrack just a little bit. How did I end up in the middle of this? Well, I went to med school at about this time. And Mont and Ross taught me at medical school. And after medical school, I went off to Oxford and I did my DPhil, the Oxford version of a PhD, on sheep. And in particular, what made sheep grow or not grow. That becomes important in just a minute. But when I came back from Oxford and did my training in newborn medicine, I joined this team, who were on staff of National Women's at the time, and you can see that Ross Howie was part of the staff. He taught me and was an important mentor for me. And I was lucky enough also to have Mont Liggins as a mentor for many years. I also met this man, David Barker, and he turned out to be important because a few years later, he started publishing this kind of stuff. And this is the relationship between size at birth along the bottom in pounds and the rate of death from heart disease before the age of 65 in men and in women. And what you see is that size at birth seems to matter. If you're born small, in this study, you were much more likely to die of heart disease than if you were born big. Now, Barker was an epidemiologist, an adult cardiologist, and he said, that's very odd. What makes babies be born small? Who was working on what made babies grow? We were, because that's what I'd done for my PhD, and that's what we were doing here. So he came here quite early on to try and find out about what makes babies small or big at birth. We'll come back to that story, but what happened in the late 60s, early 70s was the very first trial going on from that's very odd, that lamb has no right to be breathing, to steroids might help babies' lungs, to we should try it in humans, to the first human randomised trial, which is the one we're also focused on now. First part of it published in 1972, an absolutely miraculous change. And in that first report, the rate of death was decreased from 15% to 3%. We don't have many drugs and medicine that do that. The rate of lung disease decreased. There were no deaths from lung disease or bleeding in the brain in babies treated more than 24 hours before delivery. And there was no increase in infection, which is something everybody was worried about, and there was a best time to give it. And in Auckland, but not elsewhere, we've been using that treatment ever since. And what happened? Well, you can see during the period of the 70s that very remarkable increase in survival rate of preterm babies that was directly related to this trial and the use of antenatal steroids. A miracle medicine indeed. So I'm going to hand over now to Stuart Dalziel to tell you about the first 30 years.
Kia ora. Thank you very much, Jane, for that very eloquent discussion of the background to everything that happened. My name's Stuart Dalziel. I work as the Cure Kids Chair of Child Health Research here at the University of Auckland, and also for my sins late last night, I work as a paediatric emergency physician in the emergency department of Starship Hospital. So I've been involved with the story now for 20 odd years. And in fact, this story was the topic of my PhD. And what I'd like to do is take you on a little bit more of that journey and discuss how the trial that came out of the bike shed of National Women's Hospital became relevant to all women at risk of preterm birth around the world. And that's a huge number of women. 14% of babies are roughly born preterm. So that's a large proportion of our society who have a story exactly the same as Pam's and Penny's. So how good does this trial stack up 50 years later when we look at it with the lens of how we evaluate things today? So medicine's moved a little bit more on from the time of Hippocrates, where it's basically an apprenticeship model. And that apprenticeship model was fine if your mentors are Jane Harding, Liggins, and Ross Howey. But not all of us are as lucky enough to have mentors such as those three. And so over the last 40 to 50 years, medicine and how it's taught has evolved to the idea of evidence-based medicine. And at the bottom of evidence-based medicine in the hierarchy of evidence is really people like myself, so-called experts. And I'm quite comfortable being down there. But above that is observations, that remarkable observation that Liggins made on the floor of that bike shed in National Women's Hospital. But if you truly want to see if something works or not, the idea is to undertake a randomised controlled trial, where you give half the participants the active drug and half the participants the placebo, and you see if it works. And the pinnacle of evidence is where you combine multiple randomised controlled trials. And these are known as systematic reviews and meta-analysis. And internationally, the eminent organisation that undertakes systematic reviews and publishes this is the Cochrane Collaboration. And what you're seeing here in their logo is how they present evidence from combining clinical trials. Each one of those horizontal lines represents a single randomised controlled trial. And the diamond down the bottom represents combining all that evidence. And if the diamond doesn't touch the vertical line, then the evidence is significant. When Cochrane were deciding what to use as their logo, they used the story of antenatal steroids to demonstrate the benefit of clinicians undertaking systematic reviews and using that evidence. So that little bar at the top of the most well-known logo in international evidence-based medicine is the original Auckland antenatal steroid trial. And subsequent to the publication of that trial over the next 20 years, there had been 6 other studies that had published their findings. And at the start of the 1980s, if a systematic review had been done then, it would have shown clinicians that without a doubt, antenatal steroids would reduce neonatal death by 30 to 50%. But that work wasn't done until 1989. So what this logo shows you and what this logo talks about is really all the infants who died unnecessarily internationally without actually combining all that evidence and knowing it. So what does the Cochrane review of antenatal steroids look like today? So we published the review 4 years ago, and as you can see, there are a whole lot more horizontal lines on this review. But a number of things have not changed. The Liggins and Howie trial is still right at the top of the review and still remains relevant to clinical medicine 50 years later. The diamond at the bottom, combining all the evidence for the outcome of neonatal death, is very similar to what was found by Liggins and Ross Howie. It is very similar to the Cochrane logo as well. There have been over 11,000 women from 27 trials who've been randomised to antenatal steroids. The reduction in respiratory distress syndrome is 29%. For bleeding into an infant's brain because it's immature, that's reduced by 42%. These things result in a reduction in neonatal death, a reduction of developmental delay in the offspring as well. The drug is safe for the mothers. There's no difference between the two groups. And this evidence is robust across all settings. There have been studies done in sub-Saharan Africa. There have been studies done in well-resourced settings. They all show the same thing. So what we're left with is the WHO recommending that this treatment be used universally, regardless of your resource setting, around the world for women at risk of preterm birth. It's recommended by the American College of Obstetrics and Gynecology. It's recommended by NICE in the UK. It's recommended by our binational guidelines across Australia and New Zealand. And most importantly, across the road at Auckland City Hospital, today we use the same treatment that we used 50 years ago today. So how good does that trial actually stand up to how we look at studies now? So in a Cochrane review, they look at the quality of the studies. They look at 7 different domains, and from each of those domains, they look at potential bias. And they rate it a little bit like a traffic light. So green is good, it means the trial's at low risk of bias. Yellow means it's unclear risk of bias. Red's not so good. That means that the trial's at high risk of bias for the domain. If we use this lens to look at the trial that was done 50 years ago, this is what we see. So of those 27 trials, there are only 4 trials like this that have 7 green crosses. So the quality, the robustness of the scientific rigour that Liggins and Ross Howie used 50 years ago today stands up to the highest rigour of looking at clinical trials today. And despite that rigour of how they approached the problem that they were looking at, they were aware at the time that there were some unanswered questions. And this is a quote that is taken from the end of their paper. It's hoped that firm conclusions can eventually be drawn on such questions as the effect of corticosteroids on long-term development of survivors. So even though they had found a reduction in respiratory distress syndrome, a reduction in neonatal death, they were aware of the importance of following the survivors to look at the long-term effects of this treatment. And they followed the first 318 survivors. And just like Penny, who can remember being evaluated at 6 years of age, these individuals were evaluated at 4 and 6 years. They looked at both their physical health, obviously how fast they could run. They also looked at their neurodevelopmental outcomes as well. And what they found is that there was no clinical difference between the participants who had been exposed to the steroids and who had not been exposed to the steroids. So this treatment was incredibly safe and had long-term consequences that we were not worried about at all. And that's pretty much how the story went until about 25 years later when this gentleman came along. And Jane's already introduced him, David Barker, and his findings that size at birth was important for your later health outcomes. And one of the hypotheses for what drove that size at birth was excess exposure to steroids in utero. That actually drove the baby to be born small, and that actually drove the changes that he was observing. But what he was doing is making observations. He was finding associations. He was an epidemiologist. I want to take you back to that triangle of the hierarchy of evidence-based medicines. And what trumps observations is a randomised controlled trial. And what we had here in New Zealand was a randomised controlled trial. It was the largest, it was the oldest, of a group of babies who were exposed to steroids and a group of babies who were exposed to placebo in utero. And this is where the idea came from to undertake the steroid follow-up study. This photo is over 20 years old. I'm certainly looking a lot younger in it. You may not recognise me. Jane, of course, looks exactly the same. Between Jane and I is Ross Howie. Between David and Jane is Mont Liggins. And truly, the three individuals who are in this photo are the drivers of this work, and definitely the people who we recognise today, and incredibly grateful that their families could be here today as well. So we kind of knew that we had a trial where children had been randomised to one treatment or children had been randomised to another treatment. All we really needed to do was kind of ring up the children and get them to come along to the study. Jane took over Ross's office, overlooking the bike shed in National Women's Hospital next to the paddock where Mont and Ross kept the sheep. And down the corridor from her office was a cupboard. And in this cupboard, meticulously handwritten by Ross, was the trial records for each of the 1,218 babies who had been part of that study. All we knew from those records was their mother's surname at the time that they were born, their sex, and their date of birth. So we had to really kind of try and find them. We went to the attic of National Women's Hospital, we went to the basement of National Women's Hospital, and we were lucky enough to find the birth records for the years that we were interested in. We were able to find the original trial notebooks as well. We then used this information and information from birth, deaths and marriages, information from the hospital system at the time, information from the electoral roll, information from the white pages. This is before before you could search everyone up on Google, and we then tried to find the original participants. Now, if your mother's surname was Dalziel, that wasn't too much of a problem because it's a relatively uncommon name, and there was probably only one individual born in 1972, the year of my birth, called Dalziel. If your mother's surname was Smith, that was a little bit more of an issue. So there were 988 neonatal survivors. We managed to track down 72% of those at 30 years. Unfortunately, 42 of the individuals had died between 28 days of age, mainly in childhood, to that 30-year follow-up. But very generously, and a number of them are in the front rows today, 534, so 80% of those who we knew were alive and we had found participated in the steroid follow-up study. So what did we find? Well, only 60% of them were still living in Auckland, and the rest had scattered around the country. 85% of the participants still lived in New Zealand, and we sent the research nurses out to visit those families around the country. 15% of the participants lived overseas. Unfortunately, the New Zealand health budget does not extend to flying nurses to Bermuda, despite the number of times that they requested for that to happen. But we were very generous in that a number of the participants came back to New Zealand while we were undertaking the study during their holidays and kindly gave up half a day to take part in the study. So what did we find? Well, we found no difference in cardiovascular disease, body size, blood pressure, or lipids. Remember, preterm babies had severe lung disease. We found no difference between the groups in asthma and lung function. We found no difference in the stress hormone cortisol or in bone growth, and bone growth is actually stimulated by steroids as well. We found no difference in educational attainment, socioeconomic status, executive functioning, health-related quality of life. These guys were number 8 wire Kiwis. So what we did find was a subtle difference in insulin resistance. So what you're seeing here is the results of a glucose tolerance test. So what we did is we starved the participants overnight. The nurses turned up, and we then got the participants to drink a standard amount of glucose. And we did blood tests for insulin and glucose at 30 minutes, and then repeated those at 120 minutes. What you can see in the blue line is the glucose response, and there's no difference between the dotted line and the solid line. What you can see in the red is the insulin response. And in order to get the same control of glucose, then the participants who had been exposed to steroids required more insulin. And so this is a measure of insulin resistance. It was proof of the concept that steroids was related to David Barker's work. But there was no difference between those who had been exposed to steroids and those who hadn't been exposed to steroids in terms of diabetes. So what did this mean for antenatal steroids? What it meant is that antenatal steroids reduce respiratory distress syndrome, reduce neonatal death, reduce developmental delay, reduce infants bleeding into their brain. There's no difference in the outcomes for the mothers. There is no clinical difference for the outcomes for the children at 4 years, 6 years, and indeed the adults at 50 years. So we continue to strongly recommend this treatment to every woman at risk of preterm birth. But the story and the journey doesn't finish there. So at the end of that paper describing those findings, this is what Jane and I and others wrote. Although this finding is of no clinical significance at 30 years of age, it could signify raised risk of diabetes and cardiovascular disease as this cohort ages. And so it's now appropriate for me to hand over to the team that had undertaken the 50-year follow-up of the cohort. So I'll hand over to Anthony.
Kia ora koutou and good evening. My name is Anthony Walters. I'm a medical doctor working out of Green Lane Hospital in the field of diabetes and endocrinology, or related to hormones and such. Now, as you've heard from Stuart, there was a really good rationale for starting to look at a follow-up longer than just 30 years of age. And part of this was a bit about conditions that were pretty uncommon at 30 years of age, things like diabetes, high blood pressure and cardiovascular disease, which, although there wasn't any difference between the groups who had received the steroid and received the placebo at 30 years of age, those conditions are pretty uncommon at that age. And could it be that as these conditions become more common with age, over the 40s and 50s, that could it be that a difference between the groups starts to only become evident later on? And so the idea of following up this group longer was come up with actually 20 years ago by Stuart. I was reading an interview where he had said it will probably be my PhD student who looks into this, and sure enough, I undertook this 50-year follow-up work as my PhD, taking some time out of my clinical job. So I guess the question is, how did we then follow up on people after 20 years? And some of it was using tools that actually weren't available to Stuart back 20 years ago. So we had a few developments such as Google, things that came in quite useful, Facebook, LinkedIn, social media, were all useful for finding people that had last contact with the team 20 years ago. And in fact, we even managed to find a few people that hadn't been located at the 30-year follow-up, whose first contact was 50 years ago, back in the original studies. So I thought that was pretty amazing, and some people were really surprised to hear from us. So we did actually end up back in these old notebooks and birth lists from back in the 70s. This was also a team effort, really. So Tricia, who's in the audience, was our study coordinator, and she had a team which worked with myself and the others to find people, and that was across some of the things I talked about, but we also looked into, again, the electoral roll, NHI databases to get a postal address for people to get in contact, and even sometimes we went to the last known address for a home visit to really try and see where people had moved to in the interim. So really a concerted effort to find as many people as we could to get them involved in this study at 50 years. Again, some people were around the world. We didn't have quite as many different spots. Bermuda, I don't think, was on the list this time around, but we had people across the world. And so this affected actually how we planned to do the study as well, because people spread across New Zealand and across the world. It wasn't going to necessarily be practical to get people all in for an in-person visit again. And actually what was more useful was to look at what are the specific hard outcomes that we can look at, such as have people developed these diseases that we were worried about from David Barker's work. So we started the follow-up approach with sending out a questionnaire. Now, first of all, that was something which could be done as an online questionnaire, but also as hard copy for some people. Some did it over the phone, or being really flexible with how we did that. But this questionnaire covered a range of different health outcomes and looking at not only some of the cardiovascular and related diseases, but also things such as mental health conditions, looking at what people's employment and education was like. So we got a holistic view on, was this treatment impacting in a positive or negative way in these people over time. However, to augment this data, we knew that there was a lot of routinely collected data through different government organisations that could help to give us a fuller picture of what was happening. And These organisations included the Ministry of Health, so hospital admissions data that's routinely collected on different conditions people are admitted to hospital with, prescriptions that are written for different conditions, and looking at visits to outpatient clinics. TestSafe is a repository of laboratory data or blood tests that's collected for Northland and Auckland region. That again gives us a more looking at some of the blood tests that people might have had over time. And then for some of the educational outcomes, looking at NZQA, or New Zealand Qualifications Authority data, ACC for looking at accidents, and also looking at Ministry of Justice. Now, we looked at this wide range because we had evidence from animal studies and from the work from David Barker that there were potential implications of steroid exposure, mostly in these animal studies, that could potentially affect behaviour in the offspring. So if a rat was exposed to the steroid, we saw that it was more likely to develop high blood pressure, more likely to have changes in its behaviour. But we didn't know if this was true for humans. And it didn't look like there was any sign of that at 30 years of age, but could this have developed over time? So I'm just going to share not every single result we looked at, because we looked at a lot of different things, but just a select group of outcomes that are sort of most relevant and some of the things that we're most worried about during the sort of work that had been done prior to this. So just to sort of recap in terms of the numbers we were finding at 50 years of age, so we knew there were 1,218 babies in the original study, of whom, as Stuart had mentioned, a great number had passed away in the early stages despite the incredible work with the steroids. About 73 had passed away in the intervening years. We had managed to get hold of 424 participants who ended up taking part, and a smaller group that had decided not to take part. And of that 407 that we considered lost to follow-up, a great number of those we actually had figured out that they were most likely alive, and we figured probably where they were, but we hadn't had responses from those people. So we ended up with about 46% of the those that we thought to be still alive at 50 years of age, or thereabouts. So this was a really important question, was does antenatal steroid increase cardiovascular risk? Or that's risk of things such as heart disease and strokes. And when we looked at the combination of the data from the questionnaires and the data from the Ministry of Health, and we found that there was really no difference in the rates of high blood pressure, no difference in the rates of high cholesterol, and no difference in the rates of diabetes or pre-diabetes, or having any of those conditions. And we know that these conditions carry a higher risk of developing heart disease and related conditions such as strokes. What we also looked at was, did people have things such as heart attacks, heart disease and strokes, heart failure? And that also wasn't different between groups, but that was much, much less common even at 50 years of age. This was still a relatively uncommon thing to happen. So it appeared to be safe from the cardiovascular risk perspective. But back to the lung side of things, is there had been concerns about could the accelerated development of babies' lungs lead to problems in later life with the lungs maybe not going the distance as people get older. But actually when we looked at 50 years of age, there was no difference in rates of asthma, there was no difference in rates of chronic obstructive pulmonary disease, also known as emphysema. There was a very slight difference in the percentage of people that were prescribed more than one inhaled medication, so things such as the asthma inhalers, but this, on statistical analysis, was not found to be a meaningful difference. And then we looked at whether people had been admitted to hospital with these conditions, and the number of people who had been admitted to hospital with either asthma or COPD was no different between the group who received the steroid and those who didn't. We also looked at mental health conditions, again, because of these hypothesized changes in behaviour based on that animal study work, and we found that there was no difference in the proportion of people who had been either diagnosed or treated for a mental health disorder, no difference in the proportion of people who had received prescription of medications for mental health conditions, looking at that Ministry of Health data about prescriptions, And actually, there was no difference between groups when he looked specifically at certain mental health conditions such as depression, anxiety, schizophrenia, and bipolar disorder. As a more sort of general outlook, in the questionnaires, participants were asked to rate their general health, and it was quite encouraging to see that most people rated their health in the good, very good, or excellent categories on the right-hand side there. But you'll also notice that between the blue bars, that is showing those people who'd been exposed to the steroid, and the red for the placebo, that there was very little difference between groups in how they rated their general health. In terms of highest level of education, we looked at the proportion of people who had a tertiary, secondary, or did not have either a tertiary or secondary qualification, and these were again very similar between the two groups. As shown up, the blue is tertiary education, red secondary education, and on the slide there, left being those exposed to steroid and right those exposed to the placebo. Very similar picture when we looked at employment. So we looked at a few different categories of either in full-time paid employment, some other full-time occupation, or in none of the above. And this was again very similar between the two groups. And so I guess just to summarise the work that I've talked through so far, that was no long-term effects on high blood pressure, high cholesterol, diabetes or heart disease, no differences in mental health conditions, or in either education, employment, or self-reports of general health. And this was a pattern that was repeated across all of the other outcomes we looked at, that there was no difference between the groups in their long-term health outcomes. And so the take-home message really is that a course of antenatal corticosteroids for preterm birth to mature babies' lungs appears safe in the long term, and that clinicians can continue to use this treatment to get the neonatal benefits of improved survival and what we've all heard from Jane and Stuart, without the concerns of these long-term adverse effects. Thank you.
So 2 other people involved in that 50-year study have kindly shared their stories. So we just pause. Those of you who, like me, think about preterm babies and lungs will be glad to know that Electra is actually an underwater hockey player. There's nothing wrong with her lungs. She said she got the superpowers from the steroids as a preterm baby, and that it's quite cool to have been able to contribute and to know the treatment works. And that Liggins is able to do that longitudinal effort 50 years later, the teamer, and that's very rare. So thank you for sharing that story, Electra. And Tim also tells us about his birth preterm in 1970, that the family live in Grey Lynn with the other siblings' families and grandchildren, and he received an email from us asking about taking part in the follow-up study called Anchor, and read it through and shared the story with his wife, and she encouraged me to take part, but the choice had to be mine. I was keen to go ahead. I wanted to know whether my mum had steroid or placebo. And importantly, being a parent, one of my children took part as well. He had a better memory than I did in the tests we both took part in. Blood test, weight, height, scan. He remembers receiving Pokemon cards and warehouse farm and having time off school. But Tim writes, thank you for allowing myself and my son to share our stories. So thank you for sharing those stories. And to talk about the next generation, the son taking part, Libby's going to tell you briefly about that. It's our last.
Kia ora koutou, I'm Libby, and I am a medical student who's been doing my honours this year, looking at this project, which has been really exciting. So I'm just going to talk a bit about the second generation and what we've found. So before I go any further, I want to explain some terminology we use to talk about the different generations, as it gets pretty confusing once we have so many generations involved. So around 1970, as you've heard, we had our pregnant women exposed to corticosteroids or placebo, and they were called the F0s. Their babies, who were exposed when they were in the womb, were called F1. By 2020, our F1s were around 50 years of age when the follow-up that Anthony's just been talking about was done, and some of them had had their own children, the F2s, or second generation, who we're talking about now. And these are the ones who received the Pokemon cards. So, why were we interested in potential health outcomes of the F2s? So like many of the other speakers, we had a lot of animal study evidence that suggested maybe there could be some long-term effects in the second generation. We have one small study in humans that had been done on those participants with the Pokemon cards, and 2 animal studies that had shown signs of reduced glucose tolerance in those with a parent exposed to corticosteroid compared to placebo. And this made us concerned about potentially increased risk of type 2 diabetes developing in the future in this cohort. We also saw signs in the animal studies of potential changes in the hormonal response to stress, like increases in cortisol, which Stuart briefly mentioned at the start. So these animal and human studies meant that we wanted to know more about what the health was in the second generation participants in the cohort, especially because it's difficult to extrapolate evidence directly from animals into humans, so we really needed to do a study in humans. And the human study that had been done was a small study with 61 participants, followed up when they were 5 to 10 years of age. So we really wanted to do a bigger study and follow up these participants for a longer period of time, which is where the anchor study, the topic of today, comes in. So F2 participants had to also be recruited into the study, and so these participants were told about to the study team by their parents, and then we had 2 different methods of recruiting them into the study. And that's because they were a really wide range of ages, as the F1s had all had their children at different times. We ended up with people ranging from 1 to 31 years old in this study. So for those under 16, the child would agree to participation, but because they were too young to legally consent and fill it out themselves, their parents would then fill in the consent and the questionnaires on their behalf. And those 16 and over, the parents just provided the contact details for these participants, and the study team contacted the participants directly, and then the participants filled in the consent and questionnaires themselves. And there was also a re-consent process done. If participants had their 16th birthday during the study period, we checked back in with them, or Tricia checked back in with them to make sure they were still happy with their data being used. And there are a couple of things that made it a lot easier to recruit participants. First, it was if participants knew about the study and had been told about it, they were more keen to participate. And also if their parents kept on reminding them, you better apply to those researchers. So the follow-up methods in this project were the same as in the F1 cohort. We had our questionnaire and our data linkage. So now I want to talk a bit about the baseline characteristics of our F2 cohort. So first, I want to compare the participants in this study to the F2s that we knew were eligible, but that didn't take part. And these are people who their parents told us about them, but either the parents didn't invite them to take part in the study, or the F2s themselves decided they didn't want to or couldn't be reached by the study team. So we found that our F2 participants who did participate were younger, which is likely due to the slightly different methods, where for the participants over 16, it involved contacting a whole extra person in the process. But we also looked at the differences in participants with parents exposed to corticosteroid compared to placebo. And we found that our F2 participants with a parent exposed to steroid were more likely to be in the more deprived socioeconomic group, which is likely due to chance, but we wanted to do a comparison between our findings in the more deprived and less deprived socioeconomic groups to see if there were any differences, which we did do, and we didn't find any of these differences, which made us fairly confident that our results aren't being affected by this baseline difference. So now on to the interesting stuff. We've got our primary outcome of the study, which was BMI Z-score. So BMI stands for Body Mass Index, which is a way of measuring someone's weight, but also taking into account their height. And a Z-score is just used to basically take into account the different ages of participants in this cohort. So what we've done is we've plotted these graphs, which are quite similar to the graphs that Stuart introduced on the Cochrane logo, to show the result, which is here with the blue diamond, and then the confidence interval, which is with the red bar. And what we see here is we see the red bar is crossing over this line in the middle at 0, which we call the line of no effect. So basically what we take from that is that there's no evidence of a difference between the two groups. And we've plotted some of our secondary outcomes in a similar way. And again, we see no evidence of differences between the two groups for any of these outcomes, as for every outcome, the red bar crosses that line, that vertical line there. So lots of these secondary outcomes are made up of multiple different conditions. For example, our 1+ cardiometabolic risk factor included diabetes, high blood pressure, or changes in cholesterol. We've also analysed all of those outcomes separately, so there's been a lot more going on behind the scenes. But we did see some fairly wide confidence intervals for some of our outcomes, especially you can see the general health, fair or poor, which means we're not exactly sure where in that bracket the actual truth lies. We also looked at some social and educational outcomes, as we were really interested in the overall health of these participants. And from what Anthony said, there was reason to think that maybe there could be some differences in behaviour in relation to corticosteroid exposure. But again, we didn't see any differences in outcomes between those with a parent exposed to corticosteroid compared to placebo, with all of our confidence intervals crossing that vertical line. But again, we do see some wide confidence intervals. So basically, it's a bit of a boring summary, but it's what we really wanted to see. We didn't see any evidence of differences between our F2 participants with a parent exposed to corticosteroids compared to placebo, which I'm sure is really reassuring for a lot of us in the room, for those families and healthcare providers involved in the use of antenatal corticosteroids, as it builds on the evidence explained by Anthony that we don't have any long-term effects in the F1s to suggest intergenerational safety of antenatal corticosteroids.
This is a huge amount of work by a huge team. There are too many people to name, but we did specifically want to acknowledge Tricia, because many of you will have talked to Tricia, and who led the follow-up. Tricia, wave your hand so people can identify you. Tricia's just up here. And of course, all the coordinating group in both the 30-year and the 50-year and the second generation. Lots of people providing lots of funding, because this doesn't come cheap, even though we didn't fly people to Bermuda. But the real thanks, of course, needs to go to Liggins and Ross Howie for not only doing the original trial, but very generously sharing the records from that trial with us and supporting us to do the follow-up study. Feel hugely privileged that that has happened and we've been part of this story. And really important, thank you to all of you, the participants who are here and online and elsewhere. You are really the start. We are at the end of our time. We might just close off, I think, and we'll all be around to answer questions at the end, so I'll hand over to Justin to finish.
So look, I think like me, you've all enjoyed listening to the story that's been 50 years in the making. Like all good stories, I can't let the analogy go now. It's had some great sleuthing, some intrigue, a miracle drug, and great actors. The participants, the researchers that have done this work, that have really got the evidence together, that mean that clinicians are confident to carry on using this treatment and impacting on the thousands of lives that they have been around the world. There is one little twist to the story. I've been asked to do this. So the work that Mon did was made possible by a donation from the steroids from the pharmaceutical company Glaxo, which was actually established here in New Zealand by Lewis Bieber. And he set up Glaxo Laboratories in New Zealand, so it's a very big company now, you wouldn't know that. But they donated the steroids, and that actually made this trial work. The interesting thing about it was, he didn't have any idea that that would help so many people around the world when he did it. It was a small thing for him. Ironically, several years later, it turns out his great-granddaughter was actually born premature and received a dose of this treatment. And so the impact really came back to help him. So it makes a very important point, and that is that sort of the philanthropic support that people give is really critical to the work that people do in studies like this. And so we do want to thank everybody who has given anything. It's really important, and it makes a massive difference to these types of studies. With that, this here is the QR code. Please do use it to sign up to our newsletter that comes out periodically, and you get connections from the Liggins. Please, Hanui's just going to close us out with a karakia again in a second. But please join us outside for some food. And if you are one of the babies, or the mums and dads, there's a special place for you, a baby zone. Might be a little late, but it's there. So please do gather there and have a chat, meet each other, and talk to the researchers. Hanui, would you close us out?
Kia ora everybody, and a big mihi to all the researchers and the participants in these studies. Kia ora tātou. As you know, our kai's outside, so I'll bless it for us, because I'm sure some of you are peckish and would like to have a bit of a kai. Nō reira, nau mai ngā hua, o te wāda ngā kina te waitai te wai Māori, nā tāne, nā rongo, nā tūturu whakamaua kia tīna, haumie, hui, tae ki. Kia ora everybody. Enjoy.